In the following video, we will outline classification systems commonly used for categorizing intracranial dural arteriovenous fistula. Dural arteriovenous fistulas are highly heterogeneous lesions. They occur at differing locations, and they have differing patterns of arterial inflow and venous drainage. Classification systems allow us to better understand the natural history of these disparate lesions and to help guide treatment decision making. Ultimately, treatment and management need to be individualized to a given lesion in a given patient. However, these classification systems can highlight pertinent features. Additionally, they allow us to compare management and treatment of these lesions across centers using a standardized nomenclature.
The Borden classification system categorizes dural arteriovenous fistulas into three types based on the pattern of venous drainage. In a type 1 Borden lesion, direct arterial inflow into a sinus drains out of the sinus in normal anterograde fashion. In a type 2 lesion, there is some restriction of outflow from the sinus with retrograde drainage seen into subarachnoid veins. In a type 3 lesion, there is isolated retrograde drainage involving the subarachnoid veins. This can occur in a few different scenarios. First, arterial inflow may occur directly into a subarachnoid vein. Second, the affected sinus may be completely trapped with no associated drainage out of the sinus except through reflux into subarachnoid veins. Finally, the fistula may consist of a venous varix or dural venous lake with reflux into the subarachnoid veins. Type 2 and Type 3 Borden lesions represent forms of cortical venous reflux, a particularly malignant type of venous drainage pattern which involves the subarachnoid veins. The Cognar classification system also classifies dural arteriovenous fistulas based on the pattern of venous drainage. However, compared to the Borden system, there is added detail regarding the architecture of venous drainage in higher grade lesions. There is also greater specification of the location of the arterial fistula relative to the dural sinuses and subarachnoid veins, relevant for surgical treatment consideration. A type 1 Cognar lesion is identical to a type 1 Borden lesion. The fistula involves direct arterial inflow into a dural sinus with normal anterograde drainage preserved from that affected sinus. In a type 2 lesion, there is drainage into a sinus with subsequent limitations seen in anterograde flow. This is subcategorized further in the Cognar system. In a type 2A Cognar dural arteriovenous fistula, the affected sinus has refluxed into another sinus. For example, in a right transverse dural arteriovenous fistula, reflux of flow might be seen across the torcula into the contralateral transverse sinus. In a type 2B Cognar lesion, arterial inflow is seen into an affected sinus with subsequent reflux and retrograde filling seen of subarachnoid veins, representing cortical venous reflux. In a type 2A plus B lesion, drainage is seen into the main sinus with reflux both into another sinus as well as into the subarachnoid veins. Type 3, Type 4, and Type 5 lesions are all characterized by direct cortical venous drainage without dural sinus drainage. They are divided based on the architecture of the venous drainage, with Type 3 lesions lacking venous dilation or ectasia, Type 4 lesions demonstrating venous ectasia larger than 5 millimeters, and Type 5 lesions having drainage into spinal paramedullary veins. Like the Borden system described earlier, the key point is that in the Cognar system, any lesion higher than Type 2B represents a form of cortical venous drainage, with arterial inflow into subarachnoid veins portending a more malignant natural history.
The following is a case example to highlight the prior discussion on classification systems. This specific case is highlighted in greater detail with discussion regarding management and treatment in a separate video figure included in this chapter. Here seen is a lateral projection of a left external carotid artery injection. We see a fistula involving the left sigmoid sinus. In this early arterial phase, we see that the fistula is supplied by the ascending pharyngeal artery, the middle meningeal artery, and the occipital artery.
In a later phase of the angiogram, we see that drainage out of this isolated sinus does not occur in the expected manner, but rather purely through cortical venous reflux with early opacification of subarachnoid veins along the brain surface. Here highlighted is the trapped sigmoid sinus. Here we see the retrograde drainage into the cortical veins. To summarize, this lesion represents a left sigmoid sinus dural arteriovenous fistula supplied by branches of the left external carotid artery. There is direct arterial inflow into a trapped left sigmoid sinus with subsequent drainage through cortical veins. This therefore represents a Borden type 3 lesion. In the cognard system, this would represent a type 2b lesion, providing more specificity regarding the fact that arterial inflow occurs into the dural sinus first before draining into the subarachnoid veins.
The importance of cortical venous drainage or cortical venous reflux is highlighted by the following paper. In this study, patients who had persistence of cortical venous reflux after aborted or partial treatment demonstrated an annual mortality rate of 10.4%. Similarly, in the original paper introducing the cognard classification system, hemorrhage was not seen in any of the patients who had type 1 or type 2A cognard lesions. These, again, represent lesions without subarachnoid vein involvement. However, in the higher grade lesions, all involving cortical venous drainage, hemorrhage was seen as a significant symptom in a large percentage of the patients.
In summary, cortical venous reflux predicts a malignant natural history. Regardless of which classification system is used, this is the key feature to identify during angiographic assessment of dural arteriovenous fistulas. Elimination of cortical venous reflux is the principal objective in treatment of higher grade lesions. Treatment of lower grade lesions without cortical venous reflux is typically reserved for palliation of intractable symptoms such as pulsatile tinnitus. The following is a proposed algorithm for evaluating management options of dural arteriovenous fistulas. This is detailed within the manuscript text. Please note that the first decision-making point is the presence of cortical venous reflux, again highlighting our discussion today of the popular classification systems. Additionally, note that in lower grade lesions without cortical venous reflux, treatment is generally only considered in patients with intractable symptoms.